Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hello, everyone, and welcome back to the Skin Sync podcast. This is Buccinita, and I'm so excited to welcome back my co-host, Shanna Moranti. Shanna, how are you doing?
I am so great and so honored to be back with you on Skin Sync.
And I'm especially excited tonight because you are our in-house Peds-Derm expert. And today we're going to talk about the bane of the existence of many of my patients in the clinic and a very frustrating condition to treat, Molluscum contagiosum. I think you're definitely seeing tons of this in your clinic, right? So I hope you're giving lots of good advice today.
Tons and tons of molluscum. In fact, I probably saw 3 or 4 patients with molluscum today. I saw a pair of siblings and I saw 2 other completely separate accounts. So I can't wait to dive into this subject. As you said, I love Peds-Derm. My last collaborative physician was a triple board certified pediatric dermatologist, and she is so phenomenal and has been such a wealth of knowledge. So I am certainly no Peds-Derm expert, but I absolutely love Peds-Derm. I have a ton of kids. I see a ton of kids. So love to help those kiddos out there with molluscum.
Yeah, and I don't know about you, but growing up, I don't know that molluscum was really a thing, but obviously it's pretty much ubiquitous now in our pediatric population. And I
Yeah.
did not know this, but one of the nicknames for molluscum is water warts. Have you heard of that before?
Right. I have heard of that because in Florida, it was, considered kind of like a myth that you could catch them from swimming pools, which you actually can. Water is a source of the virus. This is in the pox family of viruses. It's in the same family as chickenpox and smallpox. It's caused by the Molluscum contagiosum virus, MCV1, 2, 3, or 4. And we don't differentiate because we treat them all the same. But you're right. When we were kids, the most common pox virus out there was varicella.
Yep.
So a lot of us got chickenpox and had chickenpox, and that was a much more contagious respiratory wise and much more difficult virus to overcome. So I think our immune systems got a little bit more hardened toward the pox family of viruses, and we didn't really see a lot of molluscum. But now kiddos just don't get chickenpox much anymore, or they're vaccinated against chickenpox around age 12 months of age. So this is the most common pox virus that will walk into our offices. So we need to know how to address it, how to diagnose it, and most importantly, how to treat it, and give some parents the final word on how we're going to get rid of this virus.
So I think for me, when I first have that patient conversation, the number one question the parents always ask is, how did he or she get this? Where did
Right.
this come from? They're horrified, they're disgusted even. And
Right.
so I usually lead with, this is extremely common. Every kid in the school has it. Even if you're not talking about it, your neighbors have it, your classmates have it, they all have it. So I think when
Very
you give
true.
them that reassurance, it really just kind of makes it feel less like a stigma. They don't feel as
Absolutely.
dirty. It's not a issue of hygiene. It really is just a totally benign, common, frustrating virus. Is that kind of your same advice?
Absolutely. And I think we really need to have that transmission conversation because otherwise, they're going to go home and try to blame little Johnny at school or their friend on the playground or their classmate, who was just at a pool party with them. So it's really, really important to kind of squash that stigma. This can literally come from any skin to skin contact with another infected patient. And sometimes this is a condition that can kind of lie dormant, like a lot of viruses do, and then emerge at a time when those kids get a cold or when they have an eczema flare or what have you. If the skin barrier is compromised, they're going to be a little bit more receptive to receiving that virus because of the cracks in our skin barrier. And then they're also, if they're around it a lot or if they're involved in activities like wrestling or gymnastics or other types of, skin to skin contact type situations at school or in sports, they can definitely get it. And of course, siblings can get it. I mean, I know you have 2 boys at home. I'm sure they're always wrestling around on the floor and
Of course.
and constantly on top of each other, as my kiddos are. I always say, they're in my like little puppy pile on the floor and they're constantly all over each other. So it's very, very common for siblings to pass it between themselves. So really important for us to squash the blame game and just say, hey, look, super common virus. It happens most commonly in ages 2 to 10 years of age. It spreads very, very easily in daycare, school settings, all the things we talked about. But there are certain kids that are going to be more susceptible to this. So we do need to make those parents of our atopic dermatitis kiddos and other skin barrier kind of malfunctioning conditions aware that they may be more likely to get it.
And I think it's especially frustrating for those atopic patients because, of course, I think the parents see the molluscum, like, that's kind of all that they're paying attention to. Meanwhile,
Sure.
I'm seeing the background of this angry, inflamed eczema, and I don't know
Sure.
if it's all atopic, if it's a molluscum type dermatitis, but that's my
Sure.
my focus. And so when I tell the parents oftentimes, which we'll get into this later, but that I wanna focus on treating that inflammation, they look at me kinda sideways, like, what about these bumps?" So,
Sure.
I think,
Absolutely.
again, really giving them an understanding of why it's so important to treat that inflammation, that
Yeah.
could obviously be leading to more auto-inoculation. I think that's, especially important in that conversation.
And a really important pearl here that I learned from my collaborative peds derm, she always loves to teach her residents and to teach her APPs that if you ever see asymmetric eczema, asymmetric atopic dermatitis, look for molluscum because
Ah,
oftentimes, eczema is inflammatory. Atopic dermatitis should be symmetric, right? We should see it on both sides of the body. If you see it much more predominantly on one side than the other, it's often molluscum dermatitis until proven otherwise. So take a good look with your dermatoscope and go look for those little pox viral bumps.
that's really interesting. I don't think I've ever heard that before.
Hmm.
Okay. So let's kind of talk about just clinical. I think most of us, it's a pretty obvious diagnosis. We're seeing these kind of shiny, firm little papules. They tend to have the central umbilication. Any other typical presentations? I've actually seen some really giant molluscum. I think they're literally called giant molluscum. But
Yeah,
have you
yeah.
run into this in clinic?
You can see them and they can get quite large. They can definitely be, 6 millimeters. I've even seen 8 millimeters in size if they've
Yikes.
gone like untreated for a very long time. And of course, sometimes you'll just see the giant molluscum abscess that has a big fat molluscum with that, central umbilication in that viral core. And then you'll see a big, huge, inflammatory abscess underneath it. I actually tell parents this is a great sign. Your immune system is definitely noticing this bump now, and it's going to start to mount an immune response. But we need to quiet that down, especially if it's secondarily infected with bacteria. But absolutely, as far as picking them out, we often do not need to do a biopsy. We often can take a look with our dermatoscope and take a look for those dome shaped umbilicated papules. They're often very, very shiny. They're usually where there's skin to skin contact or where there's friction and rubbing or where you might get one area of the body that's rubbing against the other. For instance, the inside of the elbow and then the side of the flank. Those are very, very common kind of auto inoculation areas. This also can auto inoculate via scratching. So, a lot of kids will get the scratching and get really itchy from it, especially if they have concomitant atopic dermatitis and can often spread it to multiple locations. And moms will come in and say, I swear they only had 4 or 5 and now they have dozens. What happened? And so we have to explain to parents that this is something that can easily auto inoculate from scratching, shared towels, or bath linens, or sometimes just from their clothing and where it's rubbing.
Right.
As we talked about, the pools have sometimes been blamed, and there actually have been studies where they've shown live molluscum virus on like floating on the surface of a pool.
Oh God, don't tell me
But
that,
it's
please. No.
I know, but it's not very common and certainly not in cold environments. I think it's much, much more common that those kiddos, after they swam in the pool, were probably wrestling around on the playground afterward. And that's
Right.
probably where they
Right,
got it
right.
much
See, but
more than a well chlorinated pool.
now that you've said it, Shannon, now it's planted in my head. Every
Oh,
time I go to an
no.
indoor water park with my children, it is my absolute worst nightmare. I loathe it because all I see is molluscum and verruca
Oh,
virus
no.
everywhere. I see
Well,
staph and I see
a
strep, and it's
little
horrifying to me.
a little dose of UV might be good for that because sometimes although we hate UV and we want UV away, there are a lot of kind of beneficial factors to that ultraviolet light that can sometimes destroy viruses as well.
Yeah. Quick question for you, Shanna. Do you have any insight as to why some kids get this in the genital and buttock area? I think a lot of parents will Google and sometimes they see that it can be sexually transmitted. And of course, that's a horrifying thing to read about when it comes to your
Absolutely.
child. But what's really the background between why they get it in these areas?
So, oftentimes, the sexually transmitted version of molluscum is most likely seen in adults. In fact, there are providers that only see molluscum contagiosum in their adult patients, kind of in their promiscuous patient population. And so, it's certainly a very common thing, but much more common in adults. When we see it in kiddos, it's typically auto inoculated into that area. And we have to kind of blame poor hygiene. Sometimes, hygiene is not the best. Sometimes they may have just scratched all their bumps on the side of their arm and then they go to the bathroom and can unfortunately auto inoculate it to that area. And then just from skin to skin rubbing and a lot of that friction and sweat and everything that happens in that area, you can get viral transmission and viral spread. So I always, again, try to really squash that blame game and try to reassure that parent that this is much, much more common in areas of skin to skin rubbing and very unlikely to be sexually transmitted in the pediatric population. Of course, if there is ever a concern for neglect or abuse, you should absolutely dive into that and make sure that that kiddo is safe. But this is something that in kids we see everywhere.
Absolutely. So now let's kind of dive really deep into the treatment. What is your approach to that? A lot of parents will come in self-referred on their own because the pediatrician reassured them. They told them that
Yep.
molluscum is benign. It's going to go away. Don't worry
Yep.
about it. And then they're waiting a month and two and three and six, and the molluscum's still not there and it's spreading and it's horrifying. So obviously they refer themselves to dermatology and they want this molluscum gone yesterday. So what is
They
your
want it
approach?
gone
Yes.
because
What's
they
your
have been
approach? How do you kinda make that decision about when to treat, how to treat, which patient population to treat? Give
yeah.
me your insight.
I offer treatment right off the bat because I know those parents are frustrated. I have 4 kids, and I think 3 out of the 4 of mine have had molluscum, and they probably all got it from each other. So it's definitely something that I know parents can be extremely frustrated about, and I wanna give them the best options. And in my opinion, the best options are the 2 FDA-approved treatment options. Of course, before we had FDA approved treatment options, it was kind of the Wild West. There was a lot of things that we tried and a lot of things that we would do to destroy the bump or cause actual tissue destruction to wake up an immune response. Because we know if we created enough of an inflammatory reaction in an area, the immune system is going to come down and come to our rescue and say, hey, what the heck is happening? What's going on down here? And once the body mounts an immune response and actually gets that immune response to that pox virus, it's kind of like back in the day when we had chicken pox. Most patients will get this pox virus only once in their life, and then they can potentially have lifelong immunity. Unfortunately, a lot of the pediatricians out there were trained for years. Hey, just let this ride. Like, just let it go. This is a virus that is, self resolving. It will go away. But what they don't tell the parents of the patients is that it can take years to go away. Sometimes 2 to 5 years can be the average lifespan of this virus because this pox virus just does not create a lot of an inflammatory reaction on healthy skin. So it can sit there for a very long time before the immune system actually recognizes it as a threat. So when the parents come in and they're frustrated, you want to give them options. Currently, there are two. There are two FDA approved treatment options. There's cantharidin, 0.7% in a drug delivery device that is administered in office. That is number one. And that was FDA approved in July of 2023. And the second that was approved is berdazimer 10.3% gel in a nitric oxide releasing agent. That one was FDA approved in January of 2024, but it was not commercially available until 2025. And I'll tell you, it really wasn't until early 2026 that I started to get good access to this medication through specialty pharmacies. It was very difficult to access, a little bit expensive. So it's definitely something that now finally pharmacies are recognizing the need for this as an alternative. it is always great to have options. It's great to have, the two options that we have because we now have an in office treatment option that is applied by the provider once every 3 weeks. And it's a vesicant that actually creates the blistering. So, that, of course, is the cantharidin that I'm talking about. This is a very precise GMP controlled formula, and it will be applied every 3 weeks until the lesions are gone. Typically, this is about 2 to 3 treatments on average. Or you can offer the parent this berdazimer 10.3% gel in the nitric oxide releasing agent to do at home. But this is a topical that they actually have to apply at home twice daily. They have to squeeze two different medications out of two different tubes, mix them both together, become a little at home chemist, and apply it to each individual bub. I really honestly leave it up to the parents. Some parents want me to do all the work and they'd rather bring their kiddos in so that I can do it for them every 3 weeks, create some blistering, create some good destruction of these lesions and get rid of them. And then I have some parents that just can't bring their kiddos in for multiple appointments. So they would much rather apply a medication at home and they would much rather take that prescription with them. So we now have the option of a treatment that we can do or a treatment we can send them home with.
So I have not had the opportunity yet to use the berdazimer topical. Have you been
Mhm.
seeing any good results with your patient population?
I have. It creates a little bit of irritation, not nearly as much as some of the old school non FDA approved therapies. Of course, before we had these two awesome therapies, before 2023, we were using a lot of imiquimod, we were using tretinoin, we were using compounded cantharidin, which really importantly to note has been banned by the FDA. So it actually is a banned substance in the United States. If you are getting compounded cantharidin into your office, it is most likely not being made in the United States. It is being imported. And unfortunately, if you ever get into a legal situation, it can be kind of a sticky situation since there is a ban on this substance. So, this is something we have to be very careful with because compounded cantharidin can actually it can start to dissolve and evaporate down to become a much, much, much more concentrated formulation. So when it is applied, you don't always know exactly what percent cantharidin you are applying to that kiddo. How many times has that little bottle of Beetlejuice been opened by your staff? How many little wooden Q-tip sticks have gone into that little bottle of Beetlejuice, So it is something that is very, very important to make sure that you recognize in your practice. I really try to use FDA approved products whenever possible. So these two are on a lot of formularies, including a lot of Medicaid formularies. So it is really, really important to use FDA approved topical therapies. But back to your original question, the berdazimer creates some irritation. It's definitely going to create a little bit of an inflammatory response, not nearly as much as the vesicant of the cantharidin. They're not going to get blistering, but it is going to create enough of a inflammatory reaction to elicit that immune response, which is ultimately what we want.
And I think no matter what treatment we offer patients, I think the most important thing to tell them that it will take time. This is not going to happen overnight. There will likely
Absolutely.
be some level of irritation or blistering or redness or skin sensitivity with these therapies. It's not going to be perfect, and we just need to set those expectations, early and keep reminding the patient that this will take time. So, do you counsel your patients on what happens after the fact? Because I think there's a few things that I run into in clinic. Number one, of course, is that post-inflammatory erythema after the molluscum is gone. In your darker skin patients, you've got that post-inflammatory hyperpigmentation that we run into. And sometimes, even without treatment, this is still a pox virus and it can leave those little pox like scars. So, do you tell your patients this up front so they don't kind of think that your treatment is what caused it in the first place?
Every single time. I always have that conversation with patients. I think that was so astute and so smart of you to bring that up. It's really, really important to discuss the aftermath and discuss, you know, the adverse events that are possible with any medication that we're prescribing. And these are therapies that are going to create a lot of inflammation, are going to create a lot of erythema. And in the, case of cantharidin, it's going to actually create a blister. So you want to tell them that's what's expected. so that they're not afraid that they're allergic. I've had patients come in that say, I'm allergic to Beetlejuice. Well, everyone is allergic to Beetlejuice. If you put this on, you're gonna get a vesication, which is a blister formation, which is the way that our body reacts when it has this crazy, inflammatory allergic reaction. So it is something that we have to warn patients about. We do expect vesication with cantharidin, and we do expect inflammation with berdazimer. And then with both of those medications, there is always the risk of post inflammatory erythema, post inflammatory hyperpigmentation, or post inflammatory hypopigmentation. So, pigmentary changes can often occur. Of course, we should counsel our patients about sun protection and keeping them out of the sun. And then always counsel your patients that there is a risk, even if we do no treatment whatsoever, pox viruses can leave permanent scarring, just like old school chickenpox did. It's really, really important to tell your patients that the pox virus caused the scars, not the treatment.
Absolutely. So, any final tips as we close this out? And I actually have a couple quick questions for you. Number one, do you tell patients not to swim when they have active acute molluscum? And second, what do you do when they do have active atopic dermatitis with molluscum everywhere? And number three, what do you do for facial molluscum? So, there's my last three questions.
I love all of those questions. Those are all really important questions. So, number one, I definitely tell patients and parents to stay out of public pools when they are going to be treating their molluscum, especially during the vesication stage. If they are going to be blistering, I do not want them in pools. I also do not want them in bathtubs with siblings. So, really important to not bathe with a sibling. And really important not to bring this to all of Disney World, or all of your ship that you're going to be going on next week. So definitely keep them out of pools when they are in that vesication or blistering stage, and make sure that they are, kind of covering up their lesions with school or with sports. Remember, this is skin to skin contact. So if that kiddo is going to their little league, baseball game, their pee wee football league, I don't want them spreading it to the whole offensive line on that little 6-year-old pee wee football team. So make sure that they keep the lesions covered. Most athletic associations for every state have different rules and regs as far as when the kids are allowed to go back to skin contact sports. So that's also really important to check out in your area. So make sure you're advising your patients about the parameters that are involved with your state societies. Number two, with your kiddos with atopic dermatitis, they are definitely going to be more at risk for this and more at risk for sometimes a worsening case of molluscum contagiosum. It doesn't matter if there are 2 lesions or 102 lesions. The parents are obviously going to be very upset about the time that it takes to get rid of these lesions. I often tell parents we usually expect about a reduction by 50% with every treatment. So if we start with a 50 next month when I see you, and then hopefully only 20 or 25, and then down to 10, and then down to 5, etc. So that is a case where certainly it might be more than the 2 to 3 treatments, and you want to counsel them about that up front. Or if they're doing the at home treatment, you're going to want to counsel them that this is going to be at least 6 months of a battle, but we will win the war, even though it is a very long battle. So make sure your atopic kiddos understand that because of their compromised skin barrier, it's really, really important to stick with their atopic dermatitis therapies. We now know, and we've had some wonderful episodes about a lot of the beyond steroidal topical therapies that can actually help repair and restore the skin barrier. So I'd love to get kiddos on one of those therapies and treat them concomitantly while we're also treating the molluscum contagiosum. Last and final question I think you asked was about facial involvement. Actually, both FDA approved therapies included lesions in their clinical trials on the face. Every single lesion was treated in the clinical trial unless it was within 1 centimeter of a mucosal membrane. So, unless it's on the eyelid or right next to the mouth, they were actually able to apply either of the 2 therapies within the clinical trial situation. So, no longer do I say, hey, I'm going to do this treatment on your body and go home and use some tretinoin on your face. I now know we have much better data with the FDA approved therapies, whether you do the cantharidin in office or the berdazimer gel at home.
Shanna, I knew you would come with excellent tips and you did not disappoint. And I'm so glad to have you back with me on the podcast today. Um,
I am so honored to be here. Thanks everyone for listening to the Skin Sync podcast.
Thanks for tuning in to Skin Sync. Don't forget to subscribe to Skin Sync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.